So now this is kind of the scientific stuff. I hope I don't put you to sleep. But first, again, to recognize that obesity is a medical condition that we want to treat. And the associated conditions and the new conditions that I want to discuss are insulin resistance, adipose organ toxicity, inflammation, and energy storage disease. And it is precisely understanding these medical conditions that has taught me, your doctor, better nutrition. And specifically, how do the macronutrients that we consume interact with the body? And the macronutrients are the fats, proteins, and carbohydrates. So, let's talk a little about insulin. So insulin's a hormone that's produced by the pancreas. Now typically, we've kind of heard about insulin and it has something to do with diabetes and regulating our blood sugar levels, and that's all true. But that's not the main role of the insulin. The main role of insulin is to regulate energy and energy storage. And when you think about it that way, this all begins to make more sense. Again, we're regulating blood sugar. We regulate blood sugar. That's a secondary response of it. But what happens is when we eat, there's energy present in the gut, and that causes our insulin level to rise. And when food is not available, the opposite happens, okay? And one of the things that happens when insulin level is low, that's a message that the body has to rely on its own sources for energy. Now there's many hormones that regulate this control of energy in our body, but we use insulin because it's so well understood and it's the best, easiest example to talk about. So, insulin turns out to be very sensitive to dietary carbohydrates. And why is it that way? Because dietary carbohydrates are a very simple form of energy. It's easy to absorb, it's easy to utilize, it's easy to burn. And this concept that when we consume carbohydrates, it turns on this insulin switch immediately. Now, fat and protein don't affect insulin nearly as much as carbohydrate, and so we consider them a second source of energy. They have to be processed to get the energy out of the macronutrient that we consume. That's better. And this is the way it works by human design. So a little bit more about insulin. It sends a message to the insulin receptors throughout our body, and that message is, hey, there's energy floating around in our bloodstream, and it's available to absorb and use that energy. And so the cells in the body and all the muscle tissue absorb that energy. The other thing that insulin does on the end organ is it converts excess energy in the bloodstream to body fat. And so that's, of course, where we can develop the adipose tissue. And then the idea is that our body fat is this unlimited storage area. Now there's another place where we can store energy, and that's glycogen, right here, and that's in the liver and muscle. And I just throw that in because some people want to know a little bit more about everything we're talking about, but glycogen doesn't contribute to insulin resistance because it's a limited space. Now what happens when insulin levels are low, it's the reverse. Basically, it's the rule of energy conservation, that there's not perhaps a lot of energy around, so we don't want to be burning it, we don't want to be storing it, we want to release it. We want to utilize energy from the storage cells in our body. So now we start overeating. What happens? When we eat, especially the carbs, create this overload of energy, and we store it as body fat. And so as our body fat builds up, we gain weight. As a result, the pancreas now needs to pump out more insulin to keep up with the excess weight that we're now starting to gain. And then there's more insulin level, and I said, again, the more insulin there is, the more the message is to store energy, so we continue to lay down body fat, and our body mass continues to enlarge. Eventually, the insulin receptors get overstimulated because there's insulin just circulating and circulating, and it's kind of like a burnout, and they become resistant to that message of insulin. The pancreas that produces the insulin gets strained. I'm going to talk about hunger in a minute, and what we develop is the vicious insulin cycle. Scary, not that bad, but so it's just this vicious cycle of death. And the idea is we have to break that particular cycle. And this is just another slide describing insulin resistance. So this is the normal condition. The pancreas is putting out insulin. And here we have our adipose tissue. And then over time, this adipose tissue doubles in size. And now the pancreas has to pump out more insulin. And then these X's show there's now resistance in the brain, in the end organs. And so this is just another way to demonstrate that this adipose tissue, buildup of adipose tissue leads to worsening insulin resistance. So now what I want to talk about is the next medical condition, which is adipose organ toxicity. And so the idea is that the gas tank, or this organ, which we refer to now as the adipose tissue, is a toxic organ to our body. And it releases toxic substances that drive insulin resistance and inflammation. And it's toxic to every cell in our body. And another way to demonstrate this is in this slide, where in the center of the universe, we have the adipose tissue releasing all these cytokines, hormones, inflammatory substances that lead to all the diseases we see in modern society. And I use the term energy storage disease. So this is you'll never hear anyone else use this term except me. I did find a reference to it. So, but the point here is that the problem is not insulin. It's energy. It's energy storage. It's a disease of energy. And so I actually like this slide. Okay, so hunger and appetite. Insulin resistance drives hunger and appetite, and it does so. I talked about this pathologic response, that vicious cycle. So part of that is this fluctuating pathologic response of insulin. And a way to describe that pathologic response would be if you have a car that has a sluggish gas pedal, and the light turns green, and you jam it down and nothing happens, so you push harder, and then eventually the engine catches up, and then by then you're going way too fast, and it's too late. Now you have to take your foot off the gas pedal. So it's kind of a sluggish response, but then it shoots too high, it shoots too low. And the hypothalamus is where the hunger centers are in our brain. And there are many hormones besides insulin that affect this satiety, or sense of fullness. And this is a slightly complicated slide, but the point is all these hormones affect hunger and appetite back in the brain. And this is really the science of the future. These are smart hormonal drugs that regulate the hunger and appetite centers of the brain. They're not appetite suppressants, they're not derivatives of histamines, or of what am I trying to say? The appetite stimulators. They are hormonal drugs. Amphetamines, that's what I meant to say. They're not amphetamines. And we actually use some of these drugs today, such as Byetta, Victoza, Amylin. They're newer drugs, and they're great drugs. In my office, I help patients who are insulin resistant lose weight. So a little bit more about the associated conditions. And what this slide shows is that, again, every medical condition we see in modern society is related to insulin resistance, inflammation, energy storage disease, and our weight. And so, again, if we battle obesity, we're going to be saving a lot of healthcare dollars. So one of the conditions, just to point out the metabolic syndrome here under the cardiac diseases. And this is a particular concern. So if you have a particular level of obesity, high cholesterol, high blood pressure, prediabetes, it significantly increases your risk for heart attack and stroke. Some statistics about these associated conditions. If you remember in the beginning of the talk, I said that 2/3 of the population are overweight. Well, that's insulin resistance. There's the medical condition. It's not just obesity. Of the general population, almost 40% have the metabolic syndrome that I just talked about, or the pre-diabetic state. Presently, 24 million, or 8% of our country, is diabetic, and I don't believe that number. I believe it's higher because people do not come and get it recognized. And then for population over 60, 25% again are diabetic. I don't believe that. I diagnose type 2 diabetes in my patients over age 65 on a daily basis. It doesn't surprise me anymore, but some of the patients are surprised. And this statistic, 1 in 3 children will be diabetic in 40 years. So basically, 8% diabetic now will become 33% diabetic in 40 years. And so this concept, a twin epidemic of diabesity, as we call it, and there's this direct relationship between weight gain, insulin resistance, diabetes, and inflammation.